Thanks everyone for joining this evening for another installment of our Synaptive webinar series. My name is Alicia McNeely and I'm a product manager with Synaptive. Today we will be hosting a discussion of the use of tractography with three highly esteemed neurosurgeons. We have some topics queued up that were sent in by the audience during the registration process, but if you have any questions during the discussion, please feel free to pose them in the questions tab through the GoToMeeting. I will be curating the questions and will do my best to fit them in. First, I'd like to provide some background on Synaptive for those of you new to the organization, and then we will get into the discussion. So Synaptive is a Toronto-based medtech company founded in 2012. We began commercializing products in 2015, and since that time, we've installed over 70 systems globally, most of which include our full surgical offering. And with these products, we've performed over 10,000 clinical cases around the world. Lastly, I'd like to mention that we have a strategic partnership with Stryker, which allows certain divisions of Stryker to market and sell our products. Thank you to our Stryker colleagues for joining us this evening. So a little bit about our products. Today we're going to be focusing on tractography, but Synaptive plays in the surgical planning, navigation, and visualization space, and most recently, the MRI space. So the initial guiding principles that were used for product development when we were creating our products was to deliver a network of products that make surgical treatment more efficient and more patient-centric across technology. We believe that we've made great strides towards this goal with our automated and integrated platform seen here. So as I mentioned, we have the tractography product, which we'll be focusing on. We also offer a robotic digital microscope with navigation integration. And most recently, we cleared our Evry MRI, which is a 0.5 Tesla magnet. And the idea is that it's cost-effective MRI designed to limit the infrastructure burden on the hospital while improving access to MR imaging in places like the ER and ICU. The Modus Plan is our tractography product. Modus Plan produces tracks automatically throughout the entire brain, and then allows surgeons to visualize bundles like the arcuate, cortical spinal tract, optic radiations, etc., within 30 seconds or less. This is all produced automatically and is patient-specific information. Additionally, surgeons can plan trajectory-centric approaches using this patient-specific information and visualize tracks that are along a certain approach. Lastly, we can integrate things like bone imaging, vascular data, or functional data in order to be able to see all of this information in one image with the tractography. So I'd like to introduce our panel. We have three esteemed surgeons here to speak with you about tractography. So our first surgeon on the panel is Dr. Chaichana. Dr. Chaichana is a Johns Hopkins trained surgeon who practices out of the Mayo Clinic in Jacksonville. He is the director of brain tumor surgery as well as the director of minimally invasive and skull-based surgery. Dr. Chaichana specializes in treatment of and research focused on brain tumors and employs minimally invasive and brain mapping techniques in his practice. Next, we have Dr. Larry Dickinson, who completed his residency in Michigan before completing a fellowship in cerebrovascular surgery at the University of Florida. He now resides in California, where he co-founded Pacific Brain and Spine Medical Group and developed the Sutter East Bay Neuroscience Center. Dr. Dickinson has completed over 200 cases with the Synaptive platform and focuses on the treatment of vascular and oncologic disease of the brain and spine. Our third panelist is Dr. Michael Schulder, who received his MD from Columbia, followed by his residency at Einstein Medical, and then he went on to complete a stereotactic neuro-oncology fellowship at Brigham and Women's. Dr. Schulder practices at Northwell Health and is the vice chairman and residency program director of the Department of Neurosurgery, as well as the director of the Brain Tumor Center. Dr. Schulder's research is focused on image-guided surgery, and he has been published hundreds of times. All right, with that, I'm going to hand things over to Dr. Chaichana, Dr. Dickinson, and Dr. Schulder to tell you about their clinical experience with tractography. We'll start off with an introduction to the topic. Dr. Schulder, can you tell us a bit of a background on the topic of white matter and tractography in neurosurgery?
Well, if you don't mind, I'll start with a little bit of relevant history. If to go back to the middle or the late 19th century when modern brain surgery first began, because for thousands of years, humans were operating on things that were visible on the skull from head trauma or infections. But with the development of the neurological examination, it first became possible to diagnose and then operate on things inside the skull. And starting with that, and for the last 150, 160 years, there's been a steady evolution of decreasing guesswork in brain tumor surgery. So we had the neurological exam in the 1860s and 1870s, the first exam-guided craniotomies in the 1880s, X-rays in 1895, and in some cases those were able to help surgeons diagnose tumors or other anomalies inside the head. Ventriculography with air injected in the 19 teens, angiography in the 1920s and 30s. That was refined over the next few decades, pneumoencephalography injected via lumbar puncture, and then a quantum leap, huge leap with computed tomography, CT, in the early 1970s. Then MRI, just for imaging, in the 1980s. And in the mid-1990s, we saw the adaptation of intraoperative MRI, surgical navigation, otherwise known as frameless stereotactic neurosurgery, but better called surgical navigation, along with techniques for what we now call functional imaging. Functional MRI to look at areas of critically important brain cortex, and shortly thereafter, around the year 2000, diffusion tensor imaging derived white matter tractography, so we could see what is below the cortex. And that, in combination with functional MRI, allowed the possibility of a comprehensive functional map of the brain, in addition to the morphological detail obtained with MRI. But how to make tractography practically possible? In the early days, and until not very long ago, to obtain tracts for the purposes of surgical planning and navigation, the surgeon would have to pick seed points, generate the tracts in conjunction with a physicist, play with parameters such as the fractional anisotropy threshold. Do you want a broader tract for safety? Do you want a narrower tract for less interference, so to speak, with your surgery? And it all took work. And there were other vendors that developed automated tractography software, but in my experience, not until Synaptive came out with their system. And let me just digress. I have no disclosures, as Alicia showed on the slide earlier. I've got no financial skin in the game in any way. I just enjoy working with and refining and proving the validity of new techniques of image-guided neurosurgery, and automated white matter tractography that's part of a surgical navigation system is one of those. And Synaptive is uniquely positioned to do that, especially with the integration with the Modus exoscope, which is available as a 3D instrument. I've been working with it as a 2D exoscope, and in about a week, we will implement our three-dimensional exoscope. And it's going to drive everyone crazy, because myself and one other neurosurgeon in my department of 15 neurosurgeons have been using the 2D exoscope because of the other's perception of the constraints of the two-dimensionality. But once we have it in 3D, everyone is going to want to use it. It's going to replace the operating microscope, but different from other exoscopes and other tractography systems, it's all going to be an integrated system. So we're going to have the stereotactic navigation, the tractography available quickly on demand in the OR, and the three-dimensional exoscopy all in one. And we're going to have that morphologic and functional map really at our fingertips. And it's really just a very exciting time to be working in image-guided cranial neurosurgery.
That's great. Thanks, Dr. Schulder. Dr. Dickinson, how are you using tractography in your practice today, and why synaptive tractography?
Muted.
I muted myself so I wouldn't interrupt Michael. I basically use navigation for any mass that is subcortical. If I have to travel a centimeter into white matter, then it doesn't make sense to not use tractography to know what you're going to be intersecting. So that includes subcortical tumors, ventricular tumors, and intracerebral hemorrhage. I do a fair amount of vascular work, and so we do a lot of intracerebral hemorrhage work as well. In addition, I also use it for tracking recovery. So when I do tumor work or ICH evacuations, my post-op imaging I do with tractography as well, because we're looking at whether we think that DTI can predict subsequent functional recovery. It's more of an interest in seeing if that's going to be the case. So those are kind of the settings in which I'm using the tractography software. Much as Michael said, the main reason I went to using Synaptive was related to its ease of use. Not only, before we had that, we had the same software company that helped us with developing our functional MRI system, had the capacity to collect DTI data and process it, but it was, in any given case, I would have to do the MRI days ahead of time and then work with my radiologist and physicist basically to 6 hours of my time to get a map. And then we had much more difficulty in integrating it with the anatomical imaging. And that is all almost seamless when I use the Synaptive software. So I think Modus was a huge step forward as far as making it useful for a practitioner in more or less a private practice setting and not having a lot of resources the way an academic center might have. So those are the main reasons I went with Synaptive. I also have the integrated system with Modus V, so the idea of being able to have this all in one package is hugely efficient.
Great, thanks. And Dr. Schulder gave a great overview of sort of the history and evolution to this point. Dr. Chaichana, there's definitely a growing community of meetings like the subcortical surgery group and white matter dissection courses, as well as research like the Human Connectome project that's all centered around preserving white matter. How do you think that these resources have impacted the consideration of white matter in neurosurgery?
Well, I think it's impacted it a lot. I mean, I haven't graduated from residency too long ago. I graduated in 2015, and I remember most of our brain tumor surgery were centered on the cortex and not necessarily the subcortical white matter. With different devices that you use to access the subcortical space, we're better understanding how we can get away with certain things or how we can't get away with certain things. So these group meetings, it's interesting to see cases, research, how they are handling white matter surgery. Because as a resident, when you really have a short-term follow-up and you're seeing these patients, they have an intact neural exam. But if you do a long-term follow-up, they're never returning to work. And a lot of this damage is due to the subcortical white matter. We're identifying more of these white matter tracks, the Human Connectome project. We're seeing what other people are finding, what other people avenues or approaches that they're using to access, let's say, the atrium of the dominant hemisphere, the atrium of the non-dominant hemisphere. All these are different. People have different experiences. So these different courses and different groups are very important to see what people are doing.
Great, thank you. So that's a pretty recent evolution from 2015, and you've already seen that change. Dr. Dickinson, do you think that the consideration of white matter over this, last few years has started to impact your outcomes? And if so, how do you see that happening?
Definitely, particularly dominant hemisphere deep hemorrhages or tumors. It's being able to assure that you're not cutting across important white matter tracks makes all the difference in the world in outcome. And I feel, it makes me a lot more relaxed in the case when I know I can introduce a retractor system into the brain and feel comfortable I haven't crossed any eloquent structures. So yeah, it's definitely impacting outcomes and allowing me to feel comfortable doing cases that I might otherwise have wanted to refer to I have some centers across the bay from me. I'm in the San Francisco Bay Area, and there's some guys that kind of know what they're doing over at UC San Francisco and Stanford, but I don't need to transfer patients now. I feel very comfortable in managing basically all oncological cases.
Yeah, and
Thank
just
you.
chiming in on the white matter track stuff. I mean, I do a lot of awake brain mapping. I spent time with Hugh Defoe in France. And it's not always practical to do a large craniotomy, map every single sulcus that you're going through and every single layer. Some of these lesions are deep seated and you can't possibly map through the opercular surface white matter track before you hit the thalamus. So these tractography is kind of like a cheating way to know what's out there so that you can try to avoid it rather than try to map every way down. Oftentimes it's not practical to do a large craniotomy, keep the patient awake for hours at a time just to map to get to a certain area where you start the resection. I think tractography is a way of shortcutting that just to identify where these white matter tracks are.
Yeah, thanks, Dr. Chaichana. And that's a great segue into the paper that you recently published actually on, a case series looking at the resection of posterior medial-basal temporal region gliomas with Dr. Defoe. And in that paper, you stated that knowledge of the underlying tracks can be applied during resection to circumvent otherwise predictable deficits. So how do you think that this idea and the use of tractography to inform resection has changed in neurosurgery?
Well, it's changed from trying, so a lot of, obviously, all these cases from Hugh Defoe are all awake cases that had large pterional craniotomies and he mapped through the whole thing. Whereas my cases, I mean, I can do that, but it takes a much longer and a lot more resource. By doing the tractography, you know where the tracks are. You align your target based on trying to avoid those tracks. Knowing what tracks you're trying to avoid is very important because you need to know what symptoms are associated with deficits of those tracks and what the patient's willing to live with. So all our cases, we get neurocognitive evaluation before and after just to make sure that we identify if we cause a deficit rather than a bedside exam. And then we can correlate with the tractography that we use to see if it actually correlates with what we try to avoid during these cases.
Dr. Schulder, any thoughts on the impact on outcomes and deficits and the use of tractography in your practice?
Well, I'd like to say that we're used to thinking about eloquent brain, and I don't mean to belittle that concept. It basically means an area of brain, an injury to which will result in a major observable deficit. But the fact is there are pretty much every area of the brain, if you do something to it, is going to affect the person, whether it's obvious or not. And we're at the very beginning of using tractography in surgery, whether you do it in the Hugh Defoe manner with painstaking and really wonderful mapping, or you map out tracks that are obvious and we sort of understand what they do, and see how the patients do afterwards. It's all how we're going to increase our knowledge of the safety of subcortical surgery. And as patient tolerance and as our tolerance for deficits gets less, things that are much less than an obvious problem like paralysis or inability to speak, subtle things, changes in emotional output or ability to process complex information, we still don't really understand the role of white matter bundles in that and what to avoid. And this is something that we're going to have to work out over the next decades still. But we have the tools now to do it, and neurosurgeons are uniquely positioned to do it. So like most neurosurgeons, and I dare say my colleagues in this webinar, when I do the tractography, I look for the obvious tracks that we know about, the injury to which is going to cause a problem, and I devise a pathway to avoid those. Now, another thing that still needs to be done and is of interest to me, and I would imagine to my colleagues as well, is to, in fact, validate these tracks. Because it's one thing to see them, and it's seductive because it's all very aesthetically pleasing to see them, and it kind of looks like the brain come alive. But we do need to measure them either during awake surgery or by repeating the DTI after surgery, reprocessing the tracts and looking at the effects, if any, on patients. And I think that's incredibly interesting and important, and it's going to take a lot of work and time to work out.
Yeah, so Dr. Dickinson, I know you've started to do post-operative tractography, and maybe that's a good opportunity to talk a little bit about that and to sort of build on the use of tractography when some people say maybe you wouldn't need tractography because you know the anatomy, and using post-operative outcomes to talk to what Dr. Schulder just mentioned.
Right. Real men don't need tractography, don't need image guidance tractography because they understand brain anatomy. Well, first of all, to follow up on Michael's statement, I think as we get better at objective measures of outcome, testing patients with greater detail of what kind of deficits we actually do cause when we go into open the head, we always lose some good humor when we're operating on the brain. And the question is, we just usually can't capture it. And our patients, without good objective measures, will come into our office. Unless you give them a hemiparesis, they're going to say, I'm doing great, doc, because they want to impress you. When you actually get down to doing detailed cognitive testing, you'll find deficits in your patients. I think that's going to become the norm. It's more expensive right now for me to do those tests, but eventually I think that's going to become part of the standard of care, that we need to have pre and post-op objective measures of what we're actually doing when we put a hole in someone's head. So I love this question about, whether you need tractography. Back in '95, I gave a talk on removing vascular malformations using navigation. And Bob Spetzler said, why do you need navigation? And 5 years later, he had published 3 or 4 papers on navigation and use of brain. I think now most people won't take AVMs out without having a surgical navigation program helping them. Well, the same thing here. This is going to become the standard of care. You're not going to be able to do subcortical surgery without knowing where tracts are. And so I have an example of this tumor in the that we did about a year ago. That you can see it's mesial. It's involving pretty much the entire course of the hippocampus, and trying to decide how to. It had areas of enhancement in it, and the patient was quite symptomatic. So we were pretty convinced it was going to be an anaplastic astrocytoma at least. And you want to get a pretty aggressive resection. So if you go to the next slide, having tractography, Alicia, if you can just go to the next one, having tractography and doing this through a small aperture, you can create a course to this tumor without affecting the arcuate fasciculus or optic radiations or the inferior longitudinal fasciculus. And by looking at both pre and post imaging on this patient, we could understand why he had some improvements with respect to his preoperative deficits. Interestingly, he was unable to recall 1 of 3 words after 5 minutes of distraction. Post-op, he still couldn't do that with verbal, but we were able to show that he was able to, if you showed objects to him and then asked him 5 minutes later what those objects were, he was able to stay with it. So it's interesting following some of these patients and seeing how their recovery evolves and how it affects tractography. This is another patient who had a large hematoma within his thalamus and deep white matter on his dominant hemisphere, and devising a way to get to that clot that avoided his arcuate fasciculus and his optic radiations allowed him to regain language that I don't think would have happened if I had chosen a more standard approach to a deep clot in this location. So I think having this tool in our hands now is definitely improving outcomes. And as I said, I think we'll become, just as no one would consider doing major cranial surgery for tumors without navigation, I think it'll be the same story for tractography in the next decade.
Thank you. There's actually a live question come in that's sort of related. so maybe you can answer that. Have you ever changed your surgical plan based on tractography?
Yeah, well, most of, your planning is partly around knowing you have your tractography in place. So you can always guess where you think you're going to go, but ultimately, as you showed in that original slide, what Synaptive allows you to do, particularly when I'm using port-based operations, is you can move where your basically entry site, which sulcus you're going to operate at the base of. You can test 4 or 5 different approaches, and you pick the one that is avoiding the most tracks. So yeah, I would say every case I'm making small modifications while I'm doing the treatment planning, which is for most of these cases 20 minutes prior to putting the patient to sleep.
So for me, a great example is superior parietal lobule. From the dominant hemisphere, you think it's a safe approach. If you don't use tractography, you don't know where SLF is, or superior longifasciculus, arcuate If you have a tractography, sometimes it directs you a little bit more posterior and lateral away from the true superior parietal lobule, especially if you're trying to access the atrium. I typically think I use interparietal sulcus the most because the tractography shows that you use superior parietal lobule, you're going to cut across a lot of the SLF tracks. And so that would be a classic example of where tractography is very critical for something in that location.
I recently had a patient at whom the distal most optic radiations were, to my surprise, deflected inferiorly and even to some extent medially by the lesion. And well, that actually made the surgery easier than I thought, but it also kept me from entering in a place that would have affected the patient's contralateral visual field, probably permanently. And this is not a rare experience.
Yeah, that's great. And I think that that's another great lead into the paper, one of the quotes in the paper, Dr. Chaichana, where you talk about the shortest distance from target without considering the underlying tractography may result in traversing critical fibers. So the idea of considering this information and rather than using the shortest trajectory, potentially altering your trajectory to avoid those deficits. Do you want to just elaborate more on that topic?
Yeah, so oftentimes, especially, I don't want to say, and I love my training, we always were taught with glioma surgeries or metastatic surgery is to try to pick the shortest distance because you minimize the amount of brain that you traverse. So for example, something in like the dominant opercular surface, if it doesn't come to the surface, you still want to go perpendicular to that because you minimize the amount of cortex and white matter you go through. With tractography and understanding the tracks, that's probably not a very good course to take, but you want to move parallel with those tracks. So instead of taking a shorter track, you take a longer track to try to preserve or work parallel with those white matter tracks. And oftentimes that's a Coker's point approach or something like that, especially with tubular base approach that Dr. Dickinson, Dr. Schulder explained. So it's not always the shortest distance is the safest distance. Cognitive or consciously, you think that's the safest because you're minimizing the amount of white matter you're going through, amount of cortex. But if it's the eloquent structures, it doesn't matter how much you go through, you're going to damage it. So you have to really take into account where the white matter tracks are and try to work parallel with the ones that you have to work with if you have to work with them. If you can avoid them, it's even better. But if you have to, you want to try to work parallel with those tracks.
Dr. Schulder, we talked about the growing resources in terms of meetings and research projects, but what would you say is the best resource for people who want to dive in deeper on white matter anatomy and tractography?
Well, Alicia, I sent you a couple of papers that I'm sure you would be happy to share with anyone who asked, at a minimum, the reference, but ideally the PDFs themselves. So this first paper is from Alex Goby's group at the Brigham, and it's a really excellent overview of what is close to the current state of the art in tractography, just because this is a pretty rapidly changing field. So what you read today may no longer be current tomorrow, but this is still a very good introduction. And for people who are not familiar with it, you have to remember, like functional MRI, tractography is not an image per se. It is data that is mapped to an image derived from magnetic resonance. Well, you could say that MRI is not a true image, but we don't have to get too deep in the weeds on that. So it's data that is derived from the direction of water flow. And that's what the diffusion tensor image is, because that direction is believed to be, and there's no reason to doubt that after a couple of decades, that it's a surrogate for the direction of nerve fibers. And there are different ways to manipulate the images to improve the granularity of the data. And that kind of information is what you can learn about in this paper. But, caveat doctor, you have to understand what the tracts mean and how the manipulation of the tract, either by you or your physicist, can affect the data that you're getting, and it can also affect your surgery. So just to take a very concrete example, too big a tract, an unnecessarily wide tract will make you unnecessarily conservative in your surgery if you're resecting a tumor, let's say, whereas a too refined or too narrow tract will increase the risk that you will create a neurological deficit, because you are not going to spare nerve fibers that you would have seen and navigated away from if you had a thicker tract, to put it in purely layman's terms. And here's another paper to supplement the other one. And I think these two are a very good place to start for people who want to learn the fundamentals of tractography.
Dr. Chaichana or Dr. Dickinson, anything to add to those resources?
No, these are great. I've read some of them, but these other ones I'm going to record and try to find and read them.
The laser paper is
Send them to you. Come on, don't be stingy, Alicia.
Great. Okay. So, Dr. Dickinson, we've received a few questions about imaging protocol that you use and your workflow. So, what is your pre-op tumor planning imaging protocol? And what is the workflow to get tractography in your OR? And how has this impacted the surgical process in your hospital?
Sure. So with respect to the tumor cases, in California, you can't admit a patient a day before to get imaging. So everyone comes in the morning of the procedure to have their MRI. And in the past, we would always have to do an MRI much further in advance. Now it can be done the same morning because of the processing speed of the Synaptive system and Modus. With respect to the sequencing, we've honed it down so that we actually do the DTI image first, the sequences that are required for that, then do what we call an SPGR, it's just a very thin cut contrast T1 image. And then we work forwards on any other sequences you want, the T2 weighted images, the flare come later. And the reason we do that is you're going to map the DTI to the contrast T1 image, which is the image that has your best spatial resolution on MR. So by merging those first, if there's any movement, if the patient gets twitchy or problematic, it occurs in sequences that don't have an impact on how you're going to do the procedure for the most part. So I think early on we had more problems with that, having to take people back to MRI because we didn't like the correlation coefficients where how the DTI imaging fit with the anatomical picture. So that was very helpful. We try to do this also with our tumor work. I'm blessed to have my support tech from Synaptive live in the same town as the hospital. So I can actually call her middle of the night and have them come in so that we can do clots emergently and have the MR data, which again, because of our interest in watching tract recovery, having that pre-tractography and post is really valuable. think that answered your question as far as how we do it. But I think the big step is being able now to do the imaging in the morning. It's convenient for the patient. There's not an extra bill. So as we all know, we're worried about what is the cost of managing care when it's rolled into their inpatient stay. It looks a lot better as far as what it's costing the providers and number of care visits their patients have.
Mm-hmm. And Dr. Schulder, what types of cases are you using tractography for? And how are you integrating vascular imaging into this workflow?
Those are two separate questions, of course, but I have a low threshold for using tractography mainly, but so easy to acquire now with Synaptive. But certainly for any subcortical case, I think it is essential, like Larry said, if it isn't now, it's going to be very soon the standard of care. But not just for subcortical cases, for even extraaxial lesions that might be on the surface. I think knowing where key tracts are is still very important. Now, you asked about vascular imaging, and that's the benefit of having an integrated navigation system. So this is a patient that I operated on last month. And it was interesting. Her neurological presentation was interesting. In retrospect, she was probably having seizures that were making her periodically agitated and confused. You can see she's got a relatively large right medial parietal meningioma. She had had a CT scan coincidentally a few years ago that really didn't show this, and it certainly appeared to have grown over that several-year period. So how to approach this, certainly a transcortical approach in a way was tempting, to have a small incision, small corticectomy, 20 millimeters or so down to the lesion, but of course that would involve disrupting intact brain. So an interhemispheric approach was preferred, but especially this far back along the superior sagittal sinus, the concern is disruption of draining veins into the sinus. And rather than working this all out at surgery through a large craniotomy, it's obviously much better to know in advance where you're going to go, to plan a relatively smaller approach. And just like I said earlier, take the guesswork out of brain surgery and avoid surprises. So I do apologize. I don't think these images quite show ideally the venous anatomy that we uncovered. Next slide. The patient did have cerebral angiography and embolization. This was something that was strongly favored by one of the referring neurosurgeons, so we did it. The real benefit to me of this was that we had a Dyna CT, basically a Dyna CT venogram that we were able to import into the Synaptive navigation system. And there were two large posterior draining veins that sort of straddled the approach that I took to get to the tumor. Initially, I was going to take a somewhat more superior approach. It would have been technically a little easier and physically sort of more comfortable, but that would have disrupted that vein. So there was about a 25 millimeter gap between these veins. I was able to get down there to the tumor, and after that, the surgery was pretty much routine. And it didn't, in fact, prove to be a meningioma. We took out the forks, et cetera, et cetera. Now, this could have been worked out intraoperatively, like I said, with a big cranie, and then you say, well, we'll go above, we'll go below. But if you didn't place your craniotomy accurately in terms of the venous anatomy, you could certainly have created a lot of mischief for this patient through a venous infarct. And knowing that in advance and planning that certainly added a great deal of comfort as well as safety to the surgery.
Thank you, Dr. Schulder. And Dr. Chaichana, can you speak a little bit to how you're using tractography today. And there are a couple of live questions that are asking about whether tractography is used for patient education or deficit planning, and whether you use tractography in post-op analysis. So sort of related to the first question, but if you could address those as well, that would be great.
Yeah, so I use tractography for any intrinsic lesion. I don't really do it on the extrinsic lesions as much, but I do it for all intrinsic lesions. So that's all your gliomas, your metastatic tumors, your cavernous malformations. I don't do really vascular surgery, but mainly brain tumor surgery. For me, I'm lucky because our radiologists help with the tractography, so I typically get the imaging 1 to 2 weeks before the surgery is pre-planned ahead of time. All my cases get neurocognitive testing within 2 weeks of the surgery and 3 months after surgery, so it's pretty protocolized in my practice. The question about deficit planning, it's definitely helpful. So if you know what white matter tracks that you're going to engage, I usually tell the patients that they can have certain deficits. So if they have an SLF on the dominant hemisphere, I said we're going to look for phonetic paraphasias where you'll be talking, but you can have some problems with word pronunciation. If you're looking for ILF or something, it could be facial recognition issues. So we kind of coach them ahead of time. And I also get neurocognitive testing to see what kind of deficits they have, and typically tell them that those deficits typically get worse before they get better. So I have all this information before we actually operate.
Dr. Chaichana or Dr. Dickinson or Dr. Schulder, any thoughts on use of this for patient education or deficit planning in your practice?
Yeah, I think what Dr. Chaichana said was very fair and honest, because you have to consider the problem for which you're operating, the patient tolerance for a deficit, how much familial and social support they have. And if you have the chance to cure them of what would otherwise over time be a lethal tumor or other lesion in exchange for a temporary deficit, and if you could be quite confident that it will be temporary, obviously if it's mild, even more so, then that's a good conversation to have with the patient. And conversely, if it really looks like, let's say, taking a whole lesion out has a high risk of giving them with a permanent noticeable deficit, you could say that, in your opinion, it is not worth that aggressive approach, and that you will take out, let's say, the majority of it and deal with the rest of it some other way. And I think it's a rare patient nowadays who would not prefer that approach. And the difference is now you're doing it without guessing, you're not flying blind, and you're doing it with real information.
Yeah, I agree. Yesterday I took out a large cystic metastasis that clearly was causing a hemiparesis and compressing on what still appeared to be tracks for the cortical spinal tract that I left tumor deep that I can hit with stereotactic radiosurgery instead of trying to peel that away and know I was going to cause more white matter injury. So that knowledge ahead of time and talking to the patient about what our goals of treatment were, and thankfully she woke up stronger instead of weaker, but with the surgery from taking out the majority of the lesion, but not all of it.
Thank you. So another question from the audience: What are other options other than Synaptive to bring tractography into the operating room?
So the old school ways, the radiologist can do the segmentation based on your DTIs. It takes a lot of time, so you have to have a radiologist that partners with you. It takes a lot of time. So if you're doing it at your own institution, the radiologist can do it for you. I would be very selective on the cases you choose because it could take several hours, but that is the old school or conventional way of doing tractography.
15 years ago, doing that was a lot of fun and it felt cutting edge and you could do new stuff, but nowadays that is fortunately terribly outdated, and there's really no reason to do that.
And I can tell you in private practice, you're not going to find a radiologist who wants to spend the 6 hours to do it for you while he could, he'd be out playing golf. So yeah, it's not, it wasn't, it was time I had to spend. And as Michael said, it was exciting when it was, no one else was doing it and the publications were rare. Now there's no way I could convince myself to spend that time without having this kind of software.
So Dr. Dickinson, you talked about that, in a community hospital, you're not going to have these types of resources. What was the process like for your hospital to acquire Synaptive technology? And do you have any recommendations for other community neurosurgeons who are interested in acquiring tractography?
Yeah, I'm part of a larger healthcare system that has created a regionalized approach. So we have a service line for neurosciences, and all of the more complex cases from our 18 hospital network come to our facility. So there is added resources for that, but still purchasing this was, a greater than $1 million investment. And whenever in program development, it's always important that you talk to administrators in the language they like, which is, what's my return on investment? And with this technology, you really can't say you're going to get a great return on investment. You have to really focus on improvement in patient care, and then partner with the people who have money. So we did most of our project through going to grateful patients and finding philanthropic support, and there's a lot of luncheons with wealthy people to get them to help us in purchasing this for our healthcare system. But the buy-in isn't just with administration, it's your whole neuroscience team. You want your neurologist, your radiologist, everyone feel that this is something that is a game changer for patient care, so that you're building support throughout your medical center, and then even going out to your community and saying how this will make a difference for your community hospital. So I think as far as doing the Modus part, I really don't know what that cost is. Putting together a robotic exoscopy system, though, it's a heavy pull as far as dollars go, and unless you're doing 150 cases a year, I don't think that you can justify this just on, gee, I'm going to bring more business to your hospital and recoup $1.5 million in investment. So you really have to go from multiple different facets to come up with this with your administration.
And just to clarify, that's for the entire surgical suite that you have.
Sorry, I was kind of talking about bringing Modus V into the institution, exoscopy, and all the pieces. So I think tractography should be an easy sell from the standpoint of, it's going to make me a better surgeon and get patients out of the hospital sooner. Whether I don't know of any published data that shows that. Certainly, it should be something that comes out of our experience with tubular clot evacuation. There's some data about resecting clots, but that's not really integrated with the tractography side of things. So I think bigger centers that can start collecting some of that cost data, this could be very helpful, because there's no doubt, like the patient that I operated on yesterday with this 6-centimeter met went home this afternoon. So that wouldn't have happened without tractography and tubular surgery. Those patients are in the hospital a long time, and now I have awake cranies that I'm sending home the afternoon after surgery. So I think we should be able to collect data that's showing that tractography decreases length of stay and improved outcomes. I just haven't seen any of that published yet.
All right. Dr. Chaichana, we've talked a lot about the change in the consideration of white matter in the last few years in neurosurgery. what do you predict will happen in the next 5 to 10 years?
I think as the field is moving forward, we're going to understand what each white matter tract does in detail and identify more white matter tracts. So I think we can have like a laundry list of things that if we do this surgery, we can have these deficits, and we can coach the patients on those types of deficits that they can potentially have based on the white matter tracts that we access. Right now, most of us will just say, oh, you might have some weakness, you might have some speaking problems, but more specifically, we'll say you have coordination problems with your right hand, you may have trouble with dexterity with your index and your thumb, and things that are more specific as we understand more and more of the white matter tract anatomy and what they do. A major step in understanding this is identifying the tracts before you actually do surgery, because in the past we would just say these tracts exist somewhere in this vast territory. We did a wake brain mapping and identified these deficits, but now we're identifying what deficits we can cause or try to avoid by understanding the white matter tracts and what they do.
Dr. Schulder, what do you see for the future?
You know, when surgical navigation was introduced 1995, 1996, it was viewed as an unnecessary, esoteric technology. It's for people who don't know anatomy and so on. But of course, it's totally ubiquitous now. In fact, there's no place on the planet, basically, where neurosurgery is done where you can't find a surgical navigation station. And I'm talking about places in the so-called developing world. And this is going to be the same. The functional MRI is commonplace. It's a little more complicated because that requires patient cooperation, physics oversight, and so on. But tractography does not require either of those things with modern software like yours. And this is going to be a ubiquitous and universally adopted technique, to the extent that people in practice and trainees will, you know, they won't remember a time before it. It'll be unimaginable, like black and white TV or something like that.
Thank you. Well, we're almost out of time, and I think that's all the live questions that have come in. So unless there's any last thoughts from the panelists, we can call it here. All right. Thanks everyone for joining, and thank you to Dr. Chaichana, Dr. Schulder, and Dr. Dickinson for taking their time to share their experiences with us.
Thank you.
Thanks for having us.
Thank you.
Night.
Bye.